All right, so this lecture focuses on central auditory processing disorder or auditory processing disorder. The C I have included in parentheses because there's argument within the audiology community over whether it should be called central auditory processing disorder or just auditory processing disorder. My job is to present the information to you and to let you make up your mind. Okay, so this is what is CAPD and kind of what it's not. Okay, so what it is. So we know that hearing is the physiologic function of the ear. Okay, so what auditory processing is the difference between that physiologic function and listening. And listening is really what the brain does with the information that is heard. So that's often referred to as auditory processing. And so there are important functions that must occur for the brain to clearly process what is heard. And if you remember back to your anatomy and physiology, probably back at early in your undergrad years, you may have learned about the central auditory nervous system and how sound is relayed from the peripheral ear up to the brain. Okay, so that's the physiologic process. And then listening is what happens when the ear, or when the brain figures out what it heard. Okay. And then there is a prolific researcher, I would probably call him the auditory processing guru, Dr. Jack Katz, who is 88 years old and continues to run groups in auditory processing and give lectures. He was a longtime faculty member at the University of Buffalo. He retired probably about 15 years ago, still does guest lecturing. But has done a lot of research. And so very early on, what Dr. Katz said was that auditory processing is what the brain does with what the ear hears. So the hierarchy of processing a sound is the ear hears the message and it sends it through the outer, middle, inner ear. From the inner ear, the auditory nerve carries that signal to the brainstem, and this is where the processing begins. The brainstem sorts the sensory input that's just been received, and it sends the auditory and or language information to the temporal lobe. The temporal lobe engages the primary skills and sets the secondary skills into motion to clean up the message. The message then arrives at the receptive language center where meaning is applied. That meaning is then sent to the expressive language to produce an appropriate verbal or nonverbal response. And then finally, the executive function skills are engaged to plan, sequence, stay on task, process, all of those things. So there's a very specific hierarchy, and this is that specific hierarchy. The role of auditory processing, and actually there are 4 primary skills, okay? So the first is being able to listen to speech and noise, and also to understand that speech in noise. When we have a normal system, that normal system is able to pull out what's a wanted or desirable message, such as speech, and push back the noise. When people have problems processing, they have some difficulty doing that. Another area is understanding distorted or rapid speech. So sometimes people speak very rapidly Sometimes it's distorted. It can be both. Or speech is missing parts. So perhaps the brain misses some of the frequencies, or the brain doesn't hear where the speech is coming from. The ear should be able to effectively listen, the auditory processing should be able to listen with both ears, receive different input from both ears, and recognize that it's different input and still be able to understand it effectively. Another thing that we call both ears is dichotic or binaural hearing. So dichotic listening, binaural hearing, it just means that the ears are presented with different information and our brain is able to sort out that different information and make use of that different information. And then finally, understanding tonal and timing differences in speech. So those are the 4 primary auditory processing skills that are needed for effective communication. If one of those areas, or possibly a second area, is problematic, then what we need to do is identify auditory processing disorders in that person. So it's imperative that we evaluate the case history to look for some of the common causes. And we're going to look at some of the common causes of auditory processing disorder. We're going to look at some of the common coexisting or comorbid disorders. Utilize the appropriate screening tools. So there are 4 really good ones, but a bunch out there. Understand what tests need to be performed to diagnose an auditory processing disorder. Recognize the qualitative signs of auditory processing disorders, and be familiar with common profiles. And so 2 of the researchers that are really prolific in APD are Jack Katz, who I mentioned earlier, and Terry James Bellis. And so they have defined some categories of auditory processing disorder, and we'll get to those in just a minute. So the common causes of auditory processing disorder, there are several common causes. Developmental causes from auditory deprivation, and that is approximately 70 to 75% of auditory processing disorders have had some kind of auditory deprivation, whether it's from ear infections. This should be an indented bullet. So some of those developmental causes are ear infections, frequent illness, allergies, sinusitis, oxygen deprivation, especially at birth, and delayed growth. So about 70 to 75% of people who have or have been diagnosed with auditory processing disorders have had one or several of these infections, allergies, etc. Okay. Typically, individuals with these issues have normal hearing, normal physiologic hearing. So outer, middle, and inner ear are normal, but when it moves through the auditory system, then we have some issues. We know that people who have permanent hearing loss or fluctuating hearing loss, and that's any type of hearing loss and any degree of hearing loss, because there's a physiologic issue, we know there's going to be a listening issue or an auditory processing issue. There's no ifs, ands, or buts about it. We know that a person with hearing loss of any type is going to experience some processing issues. And so when somebody with hearing loss gets accommodations, the accommodations for hearing loss typically are better than the accommodations for auditory processing disorders. We tend to see some family history of APD. Parents may have experienced auditory processing disorders when they were younger, and their children end up having auditory processing disorders. The learning disability and neurological causes. So if there are some neurological syndromes, 5 to 10% of people with auditory processing disorder result from a learning disability or any other neurological cause, except for brain damage. That's a result of a neurological insult, such as a stroke or a head injury. People who have seizures are more likely to have auditory processing disorder. Hyperbilirubinemia is a overproduction of bilirubin, and bilirubin is a substance in the blood, and bilirubin filters out substances in the blood. So when there's an overproduction, it's really focused on trying to eliminate the excess. So babies that are born with hyperbilirubinemia often have to get a blood transfusion, and that puts them at risk for auditory processing disorders. And finally, prematurity. And that also goes up here with delayed growth, because we know that babies who are born prematurely take a little bit of time to catch up to their normal peers. So these are all of the causes of auditory processing disorder. Coexisting disorders. We have sensory integration. We know that a lot of kids on the autism spectrum have some sensory issues, and those children also experience some issues with processing. Individuals who have executive dysfunction, attention deficit, attention deficit, I can't even remember what that, hyperactive disorder, ADHD and ADD, I think they're one in the DSM now. Developmental disorders such as intellectual disability and or autism spectrum disorder, dyslexia, behavior disorders, depression and anxiety. I mean, think of a time that you may have been depressed or very anxious and how difficult it was for you to process any kind of information. So even if we have normal processing, but we're experiencing, an episode like depression or anxiety, it may manifest, temporarily. Other coexisting disorders include language disorders and reading disorders. The most common comorbid conditions of auditory processing disorder are specific language impairment, dyslexia, and ADHD. And there's APD, and I don't know what happened to this, but it did show an overlap here among the three of them. So there are people that have just auditory processing disorder. There are people that just have a specific language impairment. There are people that just have dyslexia. And there are people that have just ADHD. Then there are some that have ADHD and dyslexia, or APD and dyslexia, or APD and SLI. So each of these can occur by themselves, but sometimes they can occur together. And so sometimes it's a little hard to tease out the difference between an auditory processing disorder and a specific language impairment, or an auditory processing disorder and ADHD. So we do have some tools that allow us to look at each of these conditions and see if we can isolate one from the other. And that's what a good test battery helps do. So the first thing is to screen. And these are things that you may do in a school. If you're working in a school, all of these questionnaires or checklists are developed for children, and they are all Most of them go up to like age 12, although I think SIFTER may go up to age 15. But each of these questionnaires or checklists are screening tools, and if they score a certain number or greater, then they're referred for an evaluation. And really the four best are the Buffalo Model Questionnaire, the Fisher's Auditory Checklist, the SIFTER, and CHAPS. And the SIFTER is an acronym and CHAPS is an acronym, and there's the names of those. I would encourage you to look at those. Maybe you have looked at them or used them before, but these are great tools to determine whether you need to refer a child out for an auditory processing disorder. There are other screening tools. So the SCAN-3 is a test for auditory processing disorders that does shortened testing. There are two versions, one for kids and one for adults. It's important to remember a lot of people will use the results from the SCAN-3 to diagnose, but the SCAN-3 is just a screening. It's a shortened version of a longer APD test battery. The typical test battery is as follows, and if any of you did the IAC team when you were first years, you may have had an opportunity to do this testing. This is the test battery that I use when I am doing research in this area. So we always do a peripheral hearing evaluation. In fact, in order to move on to the auditory processing battery, a person needs to have normal peripheral hearing. So if a person doesn't have normal peripheral hearing, I know that they're going to have auditory processing disorder. I don't go any further than that. If they have normal peripheral hearing, then we move on to otoacoustic emissions. I use both the distortion product and the transient evoked otoacoustic emissions, and I'm looking for any changes in either of those that might suggest a problem physiologically. We do emittance testing, which includes tympanometry, acoustic reflexes, and tone decay. And then the actual auditory processing test battery. And this is a minimal battery. Sometimes younger kids can't do this entire battery at the same time as they do the early battery. So, and in IAC, sometimes they do language testing, and you have an 8 or 9-year-old, and that's an all-day thing. It might be a little tough. I will typically bring younger kids in for the peripheral hearing evaluation, OAEs, and emittance. Maybe let them go get lunch and then do the auditory processing test. So the minimal battery is testing areas of those auditory processing skills. So distorted speech, speech and noise, localization, the ability to pick out distorted words, to be able to pick out tonal patterns. So these are the tests that I use. SPIN is speech and noise. SSW is the staggered spondaic word test, if you've seen that. Loyola, I know Dr. Ward doesn't use the phonemic synthesis test. I use this a lot. This is the phonemic synthesis is being able to blend words together. So if I give you SWIFT, you should be able to say Swift. So that's the phonemic synthesis test. The filtered words, so words are filtered at a certain frequency and above. Words in quiet and in noise, and then pitch patterns. So that's a minimal battery, so you really need to test every area of auditory processing so that you can make a judgment about whether a person has an auditory processing disorder. Earlier, I mentioned that these result patterns are from Katz, who designed the Buffalo model, and Terry James Bellis, and her model, it doesn't have a name to it, but Jack Katz's was called the Buffalo model because it was developed at the University of Buffalo, where he was a professor and researcher for many, many years. And so Katz has defined 3 areas of auditory processing deficits: decoding, tolerance, fading memory, and organization. Bellis has 8 different areas, but the integration deficit, the prosodic deficit, and the auditory association, which isn't on there, those are similar in their results to Katz's decoding, tolerance, fading memory, and organization. She has 8 areas, and 5 of them are pretty rare. So you see them, but it's rare to see them. So the very most common pattern of auditory processing disorder is called the decoding deficit. So this is the most common pattern of all that are typed and seen. And this is in the Buffalo model. And a person with decoding deficit will experience all of these: difficulty with quick and accurately processing auditory information, keeping up with the flow of communication, poor phonemic skills, slow responders in the classroom, artic errors, trouble following directions, weak oral skills, and weak spelling skills. They don't have to have all of those, but a majority of these areas are what, and we will see these areas on our test pattern. So when we do the SSW, and this is a binaural integration, so information is going into the right and left ear at the same time, and these may or may not mean anything to you, but these, when we score the SSW, we have a high-low ear effect, and we have a low-high order effect. So that means that first syllables or first syllable in the spondy word scores better than the second syllable. And this one is right ear versus left ear. So when SSW is a test that you may look at, but it's not something that you give or try to figure out without the help of an audiologist. They also have errors in their non-competing words and in their right competing words. They have reduced phonological blending skills, so on the phonemic synthesis test, they really bomb that. They can't understand filtered words. They have word discriminant errors, and they have poor phonological awareness skills. So again, these may not mean anything to you, but this is a pattern that we see when we do our test battery. Just to give you an idea, and I'm not going to read this, but I'll give you a minute to read it. This just gives you an idea of how a child in a classroom may experience Goldilocks and the Three Bears. And so when you're reading this in the classroom, particularly in the younger ages, kindergarten, first, second grade, when teachers are still reading, this child is completely lost. And when the teacher says, "How many bears were there?" this kid has no idea. He's not even sure there were bears because he's thinking pears. So that's just an example. And this example comes from Dr. Katz, who has done extensive research and put this kind of, it's not really a meme, but an idea of what happens when a child with a decoding deficit is listening to a common story. The next most common is called tolerance fading memory. And this particular type is often confused with attention issues. And if you look at some of the issues that a person with tolerance fading memory experiences, then you can understand why it might be confused with ADD. Kids with TFM have a poor attention span, short-term memory weaknesses, and are easily distracted. They can't follow multiple step directions and so on. So a kid with tolerance fading memory, and I've seen kids who have been put on medication to control ADD and it does nothing for them. That's when you kind of know it's not ADD and it's probably tolerance fading memory. So their errors on the APD battery are just the opposite. So the bad ear is better than the good ear, and the firsts are better than the lasts on the order. They have errors in the non-competing right ear and in the left competing words. They have poor auditory memory scores, and their speech and noise scores are outside of normal limits. Kids with decoding don't have any trouble in noise. Kids with tolerance fading memory have significant issues with noise. And this is that same story, the Goldilocks and the Three Bears, and how we think that a tolerance fading memory person may hear it. And so this child may know that there's a papa and a mama and a baby, but do they know it's bears? Probably not. So again, lost in the classroom. Prosodic, and this is a Bellis model, is the inability to properly utilize the prosodic features of speech to detect the differences in pitch, intonation, and syllabic emphasis that helps apply meaning to speech. The errors on the APD battery for the prosodic deficit include dichotic speech tasks. So anything that requires them to take information, different information from both ears, they're going to struggle with, as well as individually left ear deficits. On the pitch pattern test, we see deficits because they can't hear the up and down or the prosody of high and low. Auditory associative is very similar to the decoding, but with Bellis's model, it occurs a little bit later, where in the decoding model, we tend to see it around kindergarten. And in auditory associative, it doesn't typically come on until third or fourth grade when the linguistic demands in the classroom increase. But otherwise, the issues are the same. And then errors for auditory associative are bilateral deficits, so both ears score poorly on the dichotic tests or both ear tests, and speech and noise is outside the normal range. Bellis did not go on like Katz did to give us some framework for what they might be hearing, so we don't have those, but I am in a group with Dr. Katz, and he's done a lot of research. And so whatever he puts out, I listen and I pay attention and I gather, because they do a lot of research in auditory processing. So Dr. Bellis has not provided examples of what it might sound like for her patterns. So I don't have those, but I do have them for the two major patterns for the Buffalo model. Okay, so now we've done all this testing, we've done screening, we've looked at case history, We may have had a teacher and a parent and a speech language pathologist do a checklist, referred us for our testing, and we now have a diagnosis of auditory processing. What do we do with them? There are a bunch of classroom strategies. I'm just going to go right through them because I couldn't figure out how to turn off the, I couldn't figure out how to turn off the animation. So classroom strategies, and you'll look at some of these strategies, and a lot of them are similar strategies to the strategies that we use for individuals who have hearing loss in the classroom. Kids in the classroom will get preferential seating, reduce background noise if possible, use repetition, use visual cues, rephrasing, attention-getting devices. Older kids can use a note buddy or pre-teaching, clear, concise language, modify or eliminate oral exams, waiver of foreign language or allow ASL to fulfill, and using assistive technology in the classroom. So that's not all of them. That's the biggest majority of classroom strategies that we can use. We can also do some auditory training. So we know that strategies that were previously and still used for kids with hearing loss show promising results with auditory processing disorders. And so auditory training has 4 major training modules. One is analytic non-speech, where you work on syllables and sounds. Ba, 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 pa, 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 da, da, da. Which one is different? Which one is the same? Analytic is using speech. Synthetic is speech. And pragmatic is using speech and non-speech. I could spend a whole lecture on talking about auditory training. I'm happy to provide you with tools. You can look these up, but we just don't have enough time to go through each one of those. Another tool is behavior modification, and the goal of behavior modification for auditory processing is to induce self-control through reflective processing and response style. So behavior modification is really good for older kids, but not so much for younger kids who may not even know what a problem is or how to solve it. And really kindergarten, first and second grade don't have the cognitive ability to self-regulate. So behavior modification is something that we could use for older kids and even adults, but not with younger kids. Reciprocal training, you probably use reciprocal training where you take turns being the client and the clinician, and then your student does that. So the clinician models the desired behavior. The strategies are modeled in context. The clinician provides feedback after the client discusses the messages and the strategies, and then that comprehension is transferred to the client. Important to remember when you're doing reciprocal teaching that it takes many sessions, not just 1 or 2, for improvement to occur. Auditory perceptual strategies. We can work on tasks like auditory closure, noise tolerance, visual cues, and self-advocacy. In terms of decoding, there's a hierarchy, and this is a top-down hierarchy where we go from sentences to phrases to words to syllables or phonemes. Or we can do a bottom-up where we work on phonemes, syllables, words, phrases, and sentences. I usually do a bottom-up for younger kids and a top-down for older kids and adults. Some decoding strategies for younger kids is segmentation or parsing of phrases. So you can do finger plays, nursery rhymes, rhyming books. You can even use a tape recorder until the phrases are picked up. And, you know, there's even lots of great books, audio books for kids that are often slow and easy speech. And they should be able to do this in a variety of settings before you move on to some higher level strategies. You can do wordplay through recognition, cloze tasks, and you might start off the word associations with a picture of salt and pepper or bread and butter and have them, you know, pick out which one goes in here. And those are good tasks to do. These are great tasks even to do with kids who have hearing loss. Fill in the blanks. You eat soup with you can have a picture of a spoon, a fork, and a knife and have them pick it out, or older kids can just come up with the word. And then minimal pairs, and you can create rhymes, have kids pick out words that rhyme that are words and aren't words. So those are all strategies for kids who have tolerance or decoding deficits. There are two types of paid subscriptions that work on decoding. One is Lindamood Bell, where you have to go through training in order to provide this therapy. And the training is quite expensive. It's almost $1,000, and they require you to collect money from the clients that you use Lindamood Bell. Aerobics is on a CD. We have that in the clinic, and I've used that frequently. These both work on phoneme tasks at the decoding level. Aerobics you can just buy, and you can buy a clinical copy, so you can use it multiple times with multiple kids, or you can buy a home copy where it's just designed for 1 or 2 kids. But again, they're games, they're computer games that help kids work through decoding problems. Then tolerance fading memory strategies are to improve auditory memory and to desensitize to noise. And so these are some of the ways that we can work on improving auditory memory. And there's a hierarchy. So you may spend a week on preparatory attention and then rehearse, focused attention, sustained attention, vigilance, selective attention, and divided attention. So you're not going to go from preparatory attention to divided attention in a couple of weeks. This may take a year or even longer, depending on the age of the kid. And then noise desensitization involves introducing a low noise during a task. And so the noise is there, but it's maybe 10 to 15 decibels. So the student is aware that it's there. So you start with a low volume, and then you gradually increase it over time until each goal is achieved. I didn't mention organization. Organization is another one of CATS's types. It's not as common, and we see this in kids that have executive function disorders too. And so we use some strategies to assist them with discourse therapy. So the take-home message here is, that no one strategy works on any one child. There are tons and tons of strategies that we can use to work on auditory processing disorders, to improve auditory processing disorders. Some of those are even compensatory because students may not always improve in their auditory processing ability, but they can compensate and they can self-advocate. And that's really, at the end of the day, what we have to teach them if it doesn't get any better. Some kids do get better. And now some of the newer research is showing that low gain hearing aids, so these are hearing aids that have very little amplification programmed into them, are helping kids with auditory processing disorders, sensory deprivation, and ADHD to kind of improve their response to a lot of things, not just sound. So there's a new paper coming out. I have a friend at Ohio State, Gail, who does research in that area as well. I'm happy to share resources with you, but there is no one strategy that works with any one child. Sometimes it takes multiple failures before you get something that works. And it's okay to use those paid subscriptions because they're good. But sometimes they're a little bit out of reach for all patients, including low gain hearing aids. Not everybody can afford to have those. So again, no one strategy works with any one child. If you don't see progress with what you're using, try something else. I'm happy to entertain any questions. I will open a forum, and if you have any questions about auditory processing disorders, I am happy to answer them.